We're going to talk about mood disorders. And by the end of the session, we're going to try to differentiate between the presentation of depression in early and late life. Talk a little bit about suicide, risk factors for suicide, and some ways you might help your patients reduce their risk of suicide, and talk about pharm and non-pharm management of depression. We have funding from the Health Resources and Services Administration of the U.S. Department of Health and Human Services. A few different funding mechanisms, but otherwise no conflicts of interest. And we'll go past this. So most of our talks are framed around this model, the 4Ms model of age-friendly healthcare, and incorporating this model into your thinking is extraordinarily valuable. I've found it's made a big difference in our day-to-day clinical work, and also helping students structure how they talk to patients as to what are high-yield topics of information discovery, and just in general, connecting to them as people through the question about what matters to them. Really important. So today we're going to be kind of stuck on mentation, which goes across a couple categories that are really quite interrelated. The 3Ds of the 4Ms mentation. So that's dementia, depression, and delirium. We're going to focus heavily on depression, but you gotta kind of have to have these other two things on your radar when you have a depressed older adult. Dementia and delirium, that is. So before we go too far into the talk, I want to just play a quick video for you. This is from a group that tries to capture the patient experience of mental illness. So these are real patients discussing their experience with late life depression. I think it's very touching. If you can't hear, let me know.
It's amazing. I worked all my life, saved money, made sacrifices, raised a family. And when I reached a point in life where I thought I had enough money or be in a position where I could stop working and retire, I did. And then all of a sudden I woke up one day and I said, who are you? You're nobody. You're nothing.
I try to take, I don't know what, aspirins or whatever, just to relieve it. Drink a lot of water, nothing. And it just got worse and worse where I just didn't even want to get out of bed.
When I went to sleep, I'd fall asleep, and within an hour or so I'd be up, and I couldn't go back to sleep again. And then I'd wander around the house, turn the TV on, listen to something on the radio, and I'd probably fall asleep again and then get up again. And I wake up in the morning more tired than I was the night before.
My children noticed it, and they insisted I go for evaluation with a doctor, and I did. And then they started me on medication, and it did help, but you have to keep it up.
Well, anyhow, I thought about, going visit my mom and dad. Sounds funny, a man my age saying that, and then I said, you don't even have the courage to do that. And I said to myself, why are you here? You have no purpose. You might as well go and do what you're thinking you're doing.
But it is a challenge, and you really have to work at it and depend on those people who can help you.
I'm still thinking about it. I'm not sure I'll do it. I probably don't have the courage. Yet, it would probably be the best thing for everybody, because I'm worthless, I'm useless. I serve no purpose in life. The world will not change if I wasn't here anymore.
So before we go any further, any comments about these two older adults? Or Cyan, if you could give people the ability to talk, I'd be grateful.
Yes, they are allowed to talk.
Great.
So, yeah, this is Dr. Emmanuel, one of
Cool.
the pediatric fellows. It's kind of interesting how he said that the wall will not be. She said the wall will not be.
This is
different.
Shirley. Can you hear me?
Yeah.
Okay. I think one of the
I
things.
think Dr. Emmanuel was talking, Shirley. I'm sorry, one of the fellows.
I
Give
couldn't
him
hear.
just a minute. Yeah,
I didn't hear that.
sorry.
Yeah, we can barely hear him. So
Oh, you can.
Oh yeah, your volume is a little low. Yep.
if you could just speak up, please. Thank you.
Can you hear me now?
There
Yes,
you are.
better.
Yeah. Okay. Good. So it's kind of interesting when he said the wall will not change if he wasn't around, and I think that's what some people feel when they are depressed, but that's not really true. And yeah, and the other lady, she was like, it's gonna be good if she can be around the people who matters more to her, and that's the kind of spirit you want to have when you are depressed. You want to be. That's one of the good ways of addressing it. Be around a community where you can have some social interaction. Those are the two things that I got from there.
Yeah, so that's a great those are great comments. This is a very rich pair of individuals that kind of exemplify a lot of the different features of late life depression, right? And how different genders deal with it, what their prognosis might be, the cognitive distortions that take place, right? Just like you said, this idea that the world wouldn't be any different without him. This is an idea that has its root in depression. Shirley, Dr. Gerard, what were you going to say?
I was just going to say that in comparison to many people that I've seen, older adults, they presented themselves as much more together than many of the people I've seen who have been significantly depressed. Just they were both very articulate and had some insight. And I find in patients I've dealt with it, a lot of times it's really hard to figure out what is going on with them and what matters to them, other than like nothing matters. People have said that nothing matters to me anymore. So I wasn't sure what experience other people had in terms of patients who presented as depressed. These people seem so I don't want to say this facetiously, but they seem so much more together than many people that I've seen who have been depressed.
So I think, like everything, at least my take on this is that it's a matter of severity. There's multiple patient factors that input into how a particular person presents, including education, background, upbringing, culture, etc. But your point is well taken. I think certainly the woman has, is on treatment, right, and is improved and is able to represent her experience a little better. And whereas the man, despite being well put together, is still, I think, quite depressed. That presentation can be different in different older adults, different people. And certainly when we get to the point of being unable to care for ourselves at all, that degree of depression often requires hospital stay. Any other comments on this pair? I know that this is a tough video to watch after what was otherwise a very uplifting weekend, right? Yeah, lots of celebration in the city this weekend. Okay, so you could always raise a comment later on. So I'm going to turn a little bit to a case presentation of someone we might see in our clinics, right? Someone we have seen in our clinics. So Ms. Rodriguez presenting for her checkup. 71-year-old Hispanic woman from the Dominican Republic. English and Spanish speaking, so bilingual woman, retired, widowed, and living by herself in a 4th floor walk-up in Brooklyn. A lot of my patients live in 4th floor walk-ups in Brooklyn, and this is just the most difficult thing for older adults. But staying in their home is frequently also very important, despite the difficulty that comes with it. So we asked her if she had any new complaints. And she said, I haven't been feeling like myself over the past 2 weeks. She has no available collateral history, sort of different from most of our patients, and a fair spread of past medical history. Hypertension, hyperlipidemia, type 2 diabetes, osteoarthritis, and now she's having some complaints of memory change that have been sort of recurrent over the past few visits, glaucoma, history of gallstones, no endorsed past psych history, sort of very mild past surgical history, and a family history of diabetes and hypertension. So this is, this is a patient we all see frequently on our services, especially in East Flatbush, right? This is a common multi-complex patient, but common does not mean less complex, and complex doesn't mean beyond help. So we have to always focus on what we can do. So she was born in the DR, 2 siblings, 2 of whom are also deceased, I'm sorry to say. She was married for 60 years, but her husband passed away last year. She only has 1 child who's also living in New York City. She's retired from environmental services. So I hear this, I start to wonder about exposures and other things. Some folks in environmental services sometimes have unfortunate inhalation injuries, toxic exposures, etc. Christian, not attending church or a senior center. This is mostly because of the pandemic, though. Clean substance use history by her report. And on relatively few meds, right, for her conditions: metformin, hydrochlorothiazide, simvastatin, and Tylenol. And what matters to this patient is that she wants to stay in her home. This is where her child was raised, and this is where her husband passed away. I present a similar case where this was also what mattered to the patient. But when you actually ask people, right, what matters to them, this is something we hear a lot, right? I don't want to be sick in the hospital. I don't want to be in assisted living. I don't want to be in a nursing home. I want to be at home. This is where my memories are. And this is an important frame for everything else that happens to this woman for a few reasons, right? Not the least of which is it helps us plan her care and she to plan her care. But it also is a complicating factor if she is developing depression, right? If she is having a change, right? This is a place where there is both positive memory and negative memory, right? And as we're grappling with this last Ericksonian stage and we're taking stock of our lives, weighing those positives and negatives together becomes difficult for some people. And when we're facing this kind of history, right, where we think that she's alone, she's not doing as well as she could be alone, we're often, as medical providers, faced with the idea that perhaps she would be better in supported housing or in assisted living, right? Perhaps she would be better in a different environment or going back home to the Dominican Republic where maybe there is an extended family that she might live with. But that's not our job, actually, right? So our job might be to explore these options with her and see if it fits into what matters with her. But there are some implicit biases that go into some of these thoughts, and you have to check your own ageism as you're going through these encounters. And you have to keep all of the 4 M's in mind, right? Including all the 3 D's of the 4 M's. And I've included this mostly for your reference, right? When you're evaluating someone that has 2 weeks of change, The differential should include delirium, even in the outpatient setting, right? You should be screening older adults who have this sort of change for delirium. That includes using screening mechanisms like the UB2, Ultra Brief Questionnaire 2, which can be followed up by the CAM, the Confusion Assessment Method, and, of course, targeted medical assessment for changes. I'm going to go by delirium because I don't know if we have enough time to talk about it in depth today. And if you're screening for delirium in the outpatient setting, you have to be mindful that there are both hyperactive and hypoactive forms of delirium, and that's in the inpatient setting as well as the outpatient setting. Hypoactive delirium goes undetected. So somebody might just say that they have decreased energy, decreased drive to do things, right? And you might catch them in your office sort of on the down, sort of on a cognitively normal swing of their delirium. And this may not occur to you, right? But that person may have a UTI. They may have something else lingering that needs your attention that can be highly treatable. And you may go down the road of treating depression when you should be treating a metabolic disturbance. And you have to consider mentation, right? And make sure that you're screening that patient's cognition. I'm sorry, we're on depression screening. You have to be screening for that patient, screening depression in the outpatient setting as well. And there are very simple ways to do this. Many of you guys have learned to do these things already, like using simple tools like the PHQ-2. And then after a positive screen, advancing to the PHQ-9, and then stratifying your assessment and treatment based on severity, which is what we're going to talk about today. So let's talk about depression for a little bit, and we'll come back to mentation, cognition, and dementia later on in this talk. So we have a variety of different learners on this talk, so I have included as a reminder the diagnostic criteria for depression. I suspect that many of you guys are very familiar with these, so I won't belabor the point, but you have to have at least 2 weeks of at least one of either depression or loss of interest or pleasure, and 5 or more total of all of these symptoms, including depression or loss of interest or pleasure, including significant weight loss, insomnia, psychomotor agitation, fatigue or loss of energy, feelings of worthlessness or excessive or inappropriate guilt, diminished ability to think or concentrate, and recurrent thoughts of death. And so one of the things that is most troubling in psychiatry is that we are still operating on phenotypic diagnosis, right? We are diagnosing based on clinical presentation without really reliable biomarkers that would help us guide what is happening in each patient. And in older adults, this is particularly problematic. There are literally a couple thousand ways in which you can meet diagnostic threshold for having major depressive disorder. And many of these symptoms on this list can be attributable to other conditions that older adults are likely to have, right? I have a slide coming up about that. We'll come back to it. And it's important to remember when you're assessing older adults and you're assessing any adult or any patient period, that we are not treating sadness, right? Sadness is a state, right? Sadness is not clinical depression. It is a snapshot of normal emotion. It is not persistent. There were days when I was sad. I was certainly sad last Tuesday into Wednesday when I didn't know what the election was going to turn out to be. But now I'm not, right? So that sadness didn't deserve treatment. So assessing the longitudinal nature of a symptom and its associated factors is very important. And loneliness often goes hand in hand with sadness, right? A distressing feeling that accompanies the perception that one's social needs are not being met by the quantity or especially the quality of one's social relationships. That's the research definition of loneliness. These things go hand in hand, and neither one of them is necessarily an indication, certainly for pharmacologic management. So assessing exactly what's happening when a person says they're depressed is of vital importance, because for some cultures that might just mean, or some people that might just be loneliness. And we have other treatments for loneliness than meds, certainly, right? I can hook them up with some fun Zoom calls. They can be doing Zumba on Zoom, lickety split, and having a good time with some age-matched peers around the borough, and feeling a lot better about their day. But loneliness over long periods of time, right, which leads to social isolation and distress, may drive depression, right? As there is, if there is a chronic, if there's chronicity. And we've seen this a lot during the pandemic, right? Older adults are not doing as well as we would like them to be during the pandemic. They're the most at-risk group. They're staying at home. They're afraid to go back out. Their families are afraid to come see them. And this is driving loneliness, and it's driving depression. It's driving cognitive decline. There are lots of other diagnostic entities that include a depression component. We're not going to focus on all of these today. It's too much, probably even just to do mood disorders, or depression rather, but bipolar disorder, major depressive, or dysthymia, adjustment disorders, mood disorders due to another medical condition, right? Substance-induced conditions, medication-induced conditions, and other things like complex bereavements, or subsyndromal depression, which we call depressive episodes with insufficient symptoms. Another failing of the DSM-5 or our diagnostic criteria is that there is no diagnostic difference between older adults and their younger counterparts. So all of the real phenotypic variance between these populations is lost to the DSM-5. We're going to talk a little bit about that. So all of you, especially in the primary care community, are familiar with the PHQ-9. This is a broadly used tool. It's valid, it's accurate, and for use in elderly populations. It's been validated across a whole slew of different populations that you might be interested in either studying or just treating in your clinical practice, including folks with vascular depression, heart disease associated depression, diabetes associated depression. So this is why it's used, right? And the scoring on this assessment will allow you to stratify to some degree the severity of depression, right? But I would encourage you to take this tool and your assessments with a grain of salt and really consider the patient in their entirety. You really have to take a comprehensive assessment to understand each person and how their other conditions might be playing into their answers on this questionnaire. Right? So commonly in your clinics, you might find that if the score is 10 or higher, they get referred for treatment of major depressive disorder. But the symptom overlap is remarkable, right? So changes in interest or pleasure might be frontal lobe syndromes. They might be substance use. Insomnia could be obstructive sleep apnea or narcolepsy. They could have dementia. They could, again, have substance use or any number of other conditions. Energy level could be affected by heart disease or diabetes. Appetite changes can be cancer or dementia or any number of other things. Concentration can be, again, diabetes or dementia, persistent attention deficits, sensory impairments. And changes to your energy level or movement speed might be related to other things like Parkinson's or movement disorders. And so our patients, when they answer these questions, are not equipped to differentiate between what is caused by depression and what's caused by everything else that's going on in my life. They're just going to answer the question, and they might end up getting treated for something that they don't have. So you got to dig in and talk and ask. These are a useful tool, but they require clinical assessment and careful use. And the more sick someone is, the more medically complex they are, it is likely in your best interest to raise the bar for referral in your primary care setting, where you might use a cutoff of 10. Folks with higher degrees of disease severity you might raise the bar to 12, for instance. This was a cutoff that was developed for use in, I believe, diabetes with a higher degree of uncontrolled diabetes. Any questions about that? So surprisingly, in community samples, right, the actual prevalence of syndromic major depressive disorder, meaning you meet all the criteria for major depressive disorder, actually drops a little bit from younger counterparts. That varies quite a bit, though, amongst populations of older adults in community settings, depending on which population you're sampling. So we'll talk a little bit more about that in the next couple slides, but folks who have higher degrees of medical comorbidity or come from populations that have been stigmatized, disenfranchised, or perhaps have higher rates of trauma tend to have higher rates of major depressive disorder. But despite the syndromic, the low rates of syndromic major depressive disorder in the population at large, the rates of subsyndromal depression, or just having depressive symptoms, are quite high. Up to about a quarter of older adults in community settings have some depressive symptoms. And in community settings, or all settings, women tend to have more depression in late life than men. Their outcomes are better, though, which is quite positive. So you could see that the mean prevalence of depression in women is about 4.8% in late life versus 2.6% in men. And there seems to be declining prevalence with age. We think this is in part due to a survivor effect. Older adults that have outlived their age-matched peers tend to be resilient and survivors, and their cognitive and other psychosocial coping strategies tend to be a little bit stronger and more able to adapt to the changes that life throws at them. But there are ethnic differences in major depressive disorder in late life. You could see that Hispanic populations have very high rates of major depressive disorder in late life. And there's one group that's missing from this that also has extremely high rates, which is other native populations. I don't have the numbers for those handy, I'm sorry. I do have it for suicide though when we get there. Dual eligibles, right? I included this on purpose because this is our population, right? People who have both Medicaid and Medicare. The prevalence of mental illness in this group is extraordinarily higher than the general population. Up to a 36% of older adults who are dual eligible have mental illness. About 1 in 5 have major depressive disorder. And about 20% with other affective disorders and serious mental illness. And you could see that the rates of other mood disorders in veterans is also quite high. Psychiatric comorbidity is also really high in these populations, right? Especially you could see amongst primary care patients with major depressive disorder or dysthymia. 11% had PTSD in one sample, 15% had panic disorder. So if you have a patient coming into your clinic, it's not just that they're going to have depression, right? If you've diagnosed them with depression, they're likely to have other conditions that come along with it. And even if the pharmacologic management for that condition might be the same, the psychotherapeutic management is going to be very different, right? How you talk to that person might be very different. How they're going through their day might be very different, and where you send them for community resources, it's going to be different. So doing that assessment is really important. So there are a host of risk factors associated with late life depression. I see something in the chat. Dr. Gerard, this was an associative study. I actually don't remember. I have to look back. That's a good question. So serotonin transporter polymorphisms, some of these are the same as in younger adults. Certainly the serotonin transporter polymorphism contribute to risk in both populations. Neurotransmitter changes, right? There's decreased serotonergic activity, decreased serotonin production, receptor densities, and endocrine changes, right? Chronic cortisol elevation or stress leads to hippocampal changes, which drives depression, or systemic inflammation. And of course, subcortical or vascular changes lead to inflammatory cascades and other changes, as Dr. Crystal was just talking about, and other medical illnesses, including dementia and psychiatric illnesses, could contribute to late life depression risk. And of course, just to parse out one of those a little further, vascular depression, which is depression due to vascular lesions, is a major subtype of depression in late life, major subtype of late life depression, and also contributes to worse prognosis and treatment resistance in this population. Vascular depression is more likely to occur in late onset disease, right? So there's most adults with depression carry their depression with them from early life into late life. But those that develop late onset depression, especially when there's no social context for what's happening to that person, there's been no stress, there's been no change, they're not isolated. You have to stratify and do neuroimaging and look for other causes for that patient's presentation, and you're likely to find subcortical lesions, most likely. And so there's a whole separate talk on vascular depression that we can do. It would have been good to time it after Dr. Crystal's talk, actually. But in general, the pathophysiology here is that we think that their disruption of the prefrontal systems are responsible for this presentation. There's changes in executive function and resultant major depressive disorder. And so here's just a rough charting of what how we get to vascular depression. In an older adult, we have this sort of milieu of hypertension plus small capillary changes, hyperlipidemia, which causes white matter lesions, gray matter lesions, and increases vulnerability to depression. And there may be some psychosocial impact, which doesn't always have to occur, actually, but there may be bad and negative life events. And a perception of insufficient social support from family and relatives, which then leads to the vascular depression phenotype. And there are a host of psychosocial risk factors, including personality traits, neuroticism, cognitive distortions, as we saw in our gentleman earlier on, right? This negative distortion that the world didn't care about him. Stressful life events and chronic stress, low socioeconomic status. But so kind of surprisingly, other social determinants of health, which are so important to the other areas of medical outcome, the findings as to whether they impact late life depression are actually kind of variable. Older adults seem to be more resilient to psychosocial stressors, to the social determinant of health related stressors than their younger adults. And then there are some putative biomarkers, but these really deserve better validation before they move to the mainstream. Including ApoE4, beta amyloid tau, and neurotrophins like BDNF in particular. There are neuroimaging biomarkers that are under investigation, like correlation between the severity of vascular pathology and depression, which this correlation has been backed up by fMRI studies. The presence of anterior periventricular lesions are correlated highly with executive dysfunction in these patients. Hippocampal atrophy, as I mentioned earlier. However, findings from PET studies have been kind of mixed and shouldn't really be considered as worth mentioning, I guess, in this talk as of yet. And there are also folks working on EEG as a potential biomarker for late life depression, trying to move us away from DSM-5 based diagnosis. So I am not an electrophysiologist, so I included direct quotes from a group that reviewed this recently. In late life depression, there seems to be more slow wave activity and prolonged P300, latencies indicating decreased cerebral arousal and information processing, and decreased event potential localized to the anterior cingulate cortex. Oh, it's been a long day. Somehow I always get the 4 p.m. slot when all my my cognitive reserves have all run out for the day. And clinical presentation varies between younger and older adults, right? And this is really important. This leads to us, I talked earlier about overdiagnosis of depression, right, which is possible in primary care settings. But the variance in phenotype in older adults leads to sometimes underdiagnosis and underappreciation of what's happening. There may be more psychomotor disturbances. They may be either psychomotor agitated pacing or have decreased movement. They're less likely to say they're sad and more likely to have executive dysfunction. Higher levels of melancholy, meaning they're going to withdraw from their age-matched peers from social settings. More likely to have weight loss and those psychomotor changes. Loss of interest, social withdrawal, irritability, and somatic complaints. They're very, very likely to express their emotional distress, especially in our communities who have relatively little education on affective states, formal education on affective states. They're likely to express their emotional state through somatic complaints. You got to dig in, especially when the somatic complaint doesn't match with the workup, right? You got to dig in and figure out what's happening with that person. Irritability is extremely common, especially in our men in this community. And the clinical course, though, is similar to younger adults. It's relapsing and remitting or partially remitting. And there's a worse prognosis if its depression is combined with medical comorbidity, functional impairment, cognitive impairment, or other depressive illness like dysthymia, which we call double depression. So approximately about a third of older adults will recover, a third will have recurrent illness, and somewhere between 10% and 33% have persistent illness. And again, more severe illness predicts worse outcomes. So these patients that Shirley was talking, Dr. Gerard, was talking about earlier from her clinical experience, they sounded more severe and more likely to have worse outcomes for a host of reasons. And there are factors, prognostic factors that would indicate worse prognosis in addition to disease severity. Like medical comorbidity, cognitive impairment, physical impairment, male gender, and limited social support. There are also a host of protective factors. In medicine, we're always talking about the negative stuff, and we miss the stuff that keeps people healthy sometimes, right? So, and these are the things that older adults need to hear, right? You're sick right now, but so what? We're going to get you better. And this is the list of things that helps me see that you're going to get better. And that's wonderful, right? And being able to quantify these things for people is really, really powerful, right? These are the things that are in your corner. I'm in your corner, you're in your corner, and look at all this other stuff too, right? You've recovered before, right? Your mom had depression, you've seen what this does, and you know how to get better, right? Family history of depression. We've done this before, we can do it together. This is one of the many times in life when being a woman is better, right? than being a man. You're extroverted, you don't use substances, et cetera, et cetera, et cetera on this list, right? You have good coping strategies. But you also have to look at what's going on with that person. And this is where, our patient has some trouble, right? She has some medical comorbidities. To tie it back to our patient from the Dominican Republic. There's a bidirectional relationship between depression and medical comorbidity that you have to understand and be willing to discuss with your patients, especially when they're resistant to treatment. Depression is a predictor of mortality after a heart attack with a 2 to 4-fold increase in risk. Frailty drives depression, right? There's a loss of function associated with it, a loss of independence, which drives depression. And they all interact and worsen each other's outcome. The more depressed you are, the less likely you are to ambulate and engage in physical activity, the more likely you are to have worsening frailty, become more depressed, etc. Of course, cerebral vascular disease, as I mentioned earlier, and diabetes. There's a twofold risk of depression in folks with diabetes, in a moderate increased risk of diabetes leading to depression. There's a greater risk in women over men. Hip fractures, osteoporosis, other things that have or involve a loss of function or a perceived loss of function drive depression. And the same cycle I mentioned a minute ago. And there are higher rates of mortality overall in depressed elderly men with medical comorbidities and physical limitations. So depression leads to higher rates of incident disability. And this is only partially explained by social determinants of health. It's mostly explained by depression itself. And depressive episodes with insufficient symptoms, which is subsyndromal depression, right? So folks that have some depressive symptoms but don't meet the full criteria also have significant functional impairment and disability. And so this is where your jobs are really complicated, right? So I presented a picture to you in which older adults we know they're complicated. They're terribly complicated individuals. They have multiple comorbidities which can present like depression and drive the false positive rate, right? They're driving the diagnosis of depression when it doesn't exist. But this thought by itself might lead you to then underdiagnose depression or not recognize subsyndromal depression, which drives clinically significant functional impairment and disability in older adults. And so parsing apart that person's entire milieu and working in an environment in which you have a team of interprofessional healthcare providers that can fully assess each person's entire milieu is really important. And you wouldn't treat this bottom group with meds. No way, right? Meds aren't going to work for them anyway. You're going to engage them in physical therapy. You're going to engage them in social programming. You're going to send them to talk therapy. You're going to do whatever you need to do to get these people better, but it's not going to involve meds. And it's not going to actually increase your workload other than the referral, right? You're just going to get them up and moving. When you assess these people with late life depression, you have to fully assess them, right? This is our mantra in geriatrics: comprehensive assessment, targeted diagnostic testing, right? In particular, as I mentioned earlier, if you have new onset depression in late life with limited social stressors, right? Sort of normal social stressors, there might be some remote bereavements, there might be, some change in support, but nothing that you could put your finger on and say, that is what caused this episode. You got to do the neuroimaging. You got to do cognitive screening, and you have to do lab testing and look for other causes. You have to do these things or you're going to miss something. I can't tell you how many times per month, it's probably at least 3 to 5, we find hypothyroidism in our patients, right, that come with cognitive impairment or depression. And it was not attributed to their depressive phenotype. And just a quick adjustment, and the person is right as rain, and they don't need me anymore. Yeah.
One moment, Dr. Reinhardt.
Sure.
I actually had a question about that. I had a patient over at Kings County Hospital.
Sure.
Where I think she was in her 50s. We ended up finding subclinical hypothyroidism, as in the TSH was just a little bit elevated, but the T4 was normal. We got a consult for endocrinology, and they said don't do anything about it. But the patient originally presented as depressed. So what would you do in that sense where the T4 is normal, TSH is just a little bit too low, just a little bit high? Sorry, a little bit high. What would you do in that situation?
So this becomes difficult because there is some evidence from the endocrine literature, I believe, that depression itself can drive exactly that presentation. And you will find that endocrine docs are reluctant to treat those patients, which sounds like exactly what happened to you. Do you have longitudinal labs for that patient that showed a persistent, or is this like a one-off?
We ended up getting labs about a week later that were the same. I don't think we had any labs from like months earlier. It sounded like that specifically the endocrinology doctors wanted to wait like a month or two and get labs after that. And then maybe treat outpatient if there is anything to treat.
That is probably the evidence-based management for that case. And then I guess I don't know the full severity of that person's depression.
Actually, it was
Um,
pretty severe. It was a pretty severe, almost catatonic depression.
So it seems that in that case, you would be sort of ethically bound to treat the depression and follow the hypothyroidism over time. It is possible that the hypothyroidism will improve as the depression improves. I think
Thank you.
I think endocrine probably has that right. But you may go the other way, and we may find that the condition worsens and it warrants treatment. Thank you for that question. That's a good one.
Thank you.
So not only is there, significant risk to exacerbation of the medical conditions in these patients, right? There's the ultimate risk to patients with depression in late life, right? That of suicide. And so this stately gentleman here is George Eastman, who later in his life suffered from spinal cord disease, of which I'm forgetting the exact details of, but he was in severe and chronic pain. And later in his life, he decided that he had done everything that he wanted to do. He was a successful business person, right? Founder of Kodak, successful philanthropist. He is responsible for all of my undergraduate education, helped found the University of Rochester, and all sorts of other cool philanthropic groups in the Rochester surrounds. Put his affairs in order, put a gun to his chest, and ended his life. He left exactly the suicide note that we have on our screen here. To my friends, my work is done. Why wait? And so this, I choose to talk about this, and I'm sorry that I'm talking about it at the end of the day on what might otherwise have been a beautiful sunny day. But white men, elderly men, are more likely to end their lives violently than other groups. And we have to be mindful of this in our population. Thankfully, in Brooklyn, our older adults, at least in East Flatbush, don't have a lot of guns, but some of them do. And you have to assess for suicide risk in these folks. You have to do it, or you may lose someone. It doesn't have to be, a multimillionaire philanthropist. Losing anyone in our community is not acceptable in my eyes. We have to treat. And you can see over time, this is for CDC data, the most recently available CDC data, that suicide rates, unfortunately, are rising in the US. This kills me. And there are certain populations which are disproportionately affected, right? Particularly our native population. Look at this. We are just ignoring this population. So Caucasian individuals too, and the rates that you see on this slide set for African Americans are a little misleading. Actually, they look as though they're relatively lower than the other populations, which they are, but subgroups within that population are quite high, particularly African American men. My slides seem to have frozen. We're coming to the end of my time, so I'm going to go a little bit quicker. You could see that men in general, as we age, are more likely to commit suicide, with a huge spike in suicide rate as we enter into our 70s and through our 90s. And you could see that not only is there a huge spike in suicide risk among Caucasian men as we enter into later life, this is also from CDC data, but a little older, there's a second spike in suicide rate amongst elderly African American men, right? And this is our population. You have to talk to our patients about this and see where we are. So white elderly men in high income countries are completers, right? One completion per 4 suicide attempts. They use guns 72% of the time in completers. And late life depression is by and far the largest contribution to this risk. And then all these other risk factors are associated with that, including physical illness, as in Mr. Eastman, impairment in function, pain, as in Mr. Eastman, death of a loved one, social isolation, and change in social roles. We already discussed this. Conversely, our African American women do great comparatively, right? And we think that this is for a few reasons. They have increased rates of spirituality, increased sense of community, access to community resources, support groups, religious communities. They have increased rates of being the primary caretaker, which you might view as a sort of a stressor, but it anchors them to life, right? Grandma has to take care of the grandkids, which is stressful and may drive cognitive impairment later in life, but it ties them to the community and to their families. And there seems to be a certain socialization when we've studied these groups, that there is amongst African American women an accepting of hardship. There is an expectation that things will be difficult. And this expectation, this cognitive stance, allows them to be much more resilient in the face of things actually going wrong. And so their suicide rates are slightly lower, somewhat lower. And so there are primary care interventions for preventing suicide in the elderly, including the IMPACT trial, the PROSPECT trial, programs of community outreach, which were shown to be quite effective in a cohort study in rural Japan, telephone counseling, and resilience-focused methods like CBT group therapy and interpersonal therapy. I'm gonna go by this. And treatment in collaborative care settings, as we do, and I recommend that everyone does, is very effective for depression management and suicide prevention. Treatment in an interprofessional team. Treatment in general has to be stratified by severity of illness, right? Mild and moderate depression should not be treated with psychopharmacologic intervention. There are probably some person-centered exceptions to that rule, usually surrounding malignancy and some other things. But for the most part, you should be treating mild and moderate depression with talk therapy and exercise. CBT and problem-based therapy are highly effective, right? Active listening, supportive therapy is also effective. Get them involved in social programming, social services. Exercise is just as effective in meds in mild to moderate depression in younger and older adults alike, and it has the added benefit of improving their health outcomes, unlike the meds, which are likely to make their health outcomes worse in some respects, right? There's fall risk associated with the meds. You give meds and people just fall over and they break their hip. It's terrible. So if you have to use the meds, you gotta be very targeted with it, right? We don't have time to go through this, but I can make these slides available to you. These are all of the different randomized control studies that have been done looking at antidepressant treatment in older adults. So on the balance, when you're treating older adults and you have somebody with moderate to severe depression, right? They're leaning towards severe depression. If you have to use meds, these are our choices. You have to start exceptionally low in your dosing and you have to slowly titrate these meds. We tend to use sertraline and citalopram first. That's in part because these meds are the best studied in these groups. They have the least deleterious receptor profiles as compared to some of the other agents in this category, right? There's no anticholinergic activity, for instance, like paroxetine has. And these are some dosing guidelines. If you have failed SSRIs, the next treatment strategy you should use is SNRIs, which includes duloxetine and venlafaxine as first-line treatment. We've taken recently to using a lot of desvenlafaxine as well due to its favorable med-med interaction profile. But if you are stuck on cases and you don't know what to do, one of the benefits of being at Downstate is we're a place rich in geriatric psychiatrists, unlike many other places in the I'm sorry, I got distracted by the chat from Dr. Emanuel. That's right, Dr. Emanuel. I'm sorry for not mentioning that. We're a place rich in geriatric psychiatrists, and if you get stuck and you don't know what to do, just call me. Send me an email. I'll talk with you for a couple minutes. It usually can be very quickly figured out. We do make fair use of bupropion and mirtazapine for specific populations. These are things that you probably have learned already, but bupropion is quite activating, right? It promotes weight loss, no sexual side effects. If anything, it's pro-libido. And it also helps for smoking cessation. It may help also for alcohol cessation. It can be very useful. Probably shouldn't be used if the person has seizures. Mirtazapine really used in particularly populations who have cancer, HIV, or more advanced medical illnesses in which you need to increase their appetite and help their sleep. It's also sort of a mild to moderate antiemetic, similar to activity similar to Zofran. And if people are really sort of floppy, they are very melancholic, right? Decreased energy, psychomotor retardation, less energy and activity. You can use methylphenidate for this population. It can be very, very helpful, but you have to very carefully screen them. Usually you should get cardio clearance or you're going to hurt them. And when there's treatment resistance, things get a little dicey because there actually has not been a completed randomized control trial for treatment-resistant depression in older adults. There is one ongoing. It's called Optimum. I can't wait for it to come out so that I will have some evidence base to guide my management. But for the meanwhile, we sort of guide our treatment based on what we do for younger adults with dose-adjusted guidelines, right? First, if you've tried an SSRI and an SNRI, you're then going to augment with an agent from a different class. Usually, I would choose to add bupropion. If that's not working, you might consider adding thyroid hormone, which is very well tolerated, but not as effective as adding lithium. Lithium is more effective as an augmenting agent, but not as well tolerated for clear reasons. There's also a lot of dehydration in older adults because of changes to the physiologic changes to the thirst mechanism. They're not usually as well hydrated, and it becomes a risky med to do this with caution. But it does also kind of help with cognition. It may be preventive in progressing to MCI or dementia. So there's some worth in thinking about it. Or you can add an atypical antipsychotic. We usually do this as a last resort or for people with associated psychotic features. ECT is a gold standard, as we talked about previously, really effective, but access to ECT is hard. There's not a lot of places that do it, and there's a lot of stigma. I'll make these slides available to you guys, just a quick algorithm. And it's important to remember that depression may be a precursor of dementia in late life, to circle back to the last D of the 4 M's, dementia. So depression may be a prodrome of Alzheimer's disease, or it may increase the risk of progressing to dementia. And this is, of course, higher when there are vascular lesions present. So if an older adult is depressed, they should be screened for dementia. And if an older adult has dementia, they should also be screened for depression. These 3 Ds of the 4 M's have to be done together if you want to really treat someone safely. This is an algorithm to do that. This talk is too long and needs to be trimmed. All right. I'm going to go past some of this. Depression is highly prevalent in dementia and should always be considered. And back to this patient, I just want to close and give you guys closure on her case. So we did age-friendly screening on this patient. Her mobility, she rated as having moderate fall risk on the CDC STEADY algorithm. No polypharmacy, no high-risk meds. Her mini-mental was 21, previously 27, so clear change. PHQ-9 was 15, so positive screen. But she also had a positive CAM, or positive UB2, which was CAM, but she was CAM negative, sorry. And what matters, we've discussed previously, she wanted to stay in her home. Her hypertension was not well managed. She wasn't keeping a log. Her diabetes was also uncontrolled. She'd been ordering a lot of takeout. She just didn't feel like cooking. Her hyperlipidemia also not well managed. She'd been ordering out osteoarthritis. She's taken a lot of Tylenol for pain. And her memory, she sort of endorsed that she couldn't focus these past 2 weeks. It eventually came out after we dug in that her daughter had died from coronavirus 3 weeks ago. And they hadn't been able to see each other before her death due to the pandemic. And now she was just in bed all day, minimally ambulating and socially withdrawn. She came in to see us, because she trusted us, right? So she was depressed, she had anhedonia, she had psychomotor retardation, cognitive deficits, and increasing thoughts of death with no clear plan. Hasn't gone to establish preventive care. So despite the clear timeline and stressor, we completed the workup for new onset depression in the elderly. No big surprises, right? She had uncontrolled diabetes, which likely contributed to her risk. Thyroid was normal, B12 normal, nothing to write home about on the CBC. Her ESR was mildly elevated. She had vascular contribution. However, on the MRI brain, she had extensive white matter ischemic disease, bilateral basal ganglia lacunar infarcts. Chronic though, likely also contributing to her risk of depression. So we ended up sending her to physical therapy to boot her up into physical activity, group and coaching. And of course, during the pandemic, gyms are not available to most people. Maybe they are now. And we reconnected her to preventive services and connected her to psychotherapy, in this case, mostly supportive due to the bereavement. And we ended up starting her on sertraline, which was titrated up to 100 milligrams due to the severity of what she was experiencing and the incident suicidal thoughts. And then we hope to send her to a senior center in the future once they become available again. She got about 60% better, which is not what I like to tell you all. I'd like to say that she got 100% better, but that's not reality, right? We know that a third of people get better, a third of people get partially better, and a third of people really have very frequently recurrent illness. And so she fell into that middle group, despite using combination therapy. And we don't know how she's doing long-term because we're not there yet. Next year, I'll have a better update on that case. So thank you for listening to me through my long depression talk. Any questions?